السلام عليكم ورحمة الله وبركاته. مرحبا دكتور باسم. أهلا وسهلا. Hi Derek.
Hi everybody.
Hi everybody. Hi there. مرحبا دكتور باسم.
يا هلا وسهلا. السلام عليكم ورحمة الله وبركاته.
نورتونا.
Dr. Bassem.
الله يجزاك خير.
مرحبا. Thanks for joining us tonight. And I'm sure it will be very interactive with this number of audience that we are seeing on the screen. Inshallah, we will be able to deliver the main topic that we are going to address today. So with no further delay, Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. I'm honored and happy to welcome all of you today to the 9th chapter of MENASO Education Academy Cerebrovascular Grand Round for 2022, organized by MENA Stroke Organization, which is endorsed by AHA, ASA, and WSO. The Cerebral Grand Round Webinar is a unique platform that provides comprehensive education about stroke, its latest treatment and management. The focus for today's webinar will be divided by our two distinguished speakers. Update in the TNK, the new standard in thrombolysis for acute ischemic stroke, which will be delivered by Professor Derk Krieger, and the radial approach in neurovascular in Saudi Arabia, experienced by Professor Bassem Yousef. Before we start, I would like to remind our audience that this is an interactive session where our audience will be able to address their questions, comments through the Q&A box at the bottom of their Zoom. It's great that we are able to complete the next, second year of doing monthly base all these Zoom type of activity, and MENASO and the board of MENASO are happy that we are able to get a distinguished speakers at the level of the region and the globe. We will start with our first speaker, Professor Derk. Professor Derk is a professor of neurology with a very long history and experience in neurological disease. He has been specialized and interest in the cerebrovascular disease, stroke, neuroimaging, and headache. Professor Derk has been across the world, where he has been the founder and the chairman of the comprehensive stroke unit at Copenhagen Center in Denmark. Then he joined the Cleveland Foundation for more than 10 years as an associate professor. Also, he did his fellowship in critical neurocritical department at Cleveland, Ohio. He is a fellow of European Stroke Organization and a fellow of the American Heart Association, American Stroke Association. His interest in different area of research in stroke, and I'm delighted that Dr. Derk lives in the same city with me in Dubai, and he's a professor of neurology and consultant at Parkview Hospital. Tonight, Derk is going to speak about the TNK, the new standard in thrombolysis for acute ischemic stroke. Stage is yours, Derk.
Thanks, Suhail, for the nice introduction. It's a pleasure to be here, an honor to lecture at this Grand Round. And I took it upon myself to make TNK the new standard, although it is not yet the new standard because it is not yet approved. But I would like to show you why it will be the new standard within short time. Let's see here. How do we forward this? Okay. These are my confocal micrographs of a fibrin clot during fibrinolysis initiated by TPA. So you can see on the left-hand side, the initial image, and the magnification is 5 micrometers. And you can see towards the right-hand side, the successive working of the TPA in this fibrin clot So in B, it is 147 seconds later. You can see that little red rim coming up on the left lower bottom of the image. In C, it's 196 seconds later. And on 245 seconds later on the right-hand side, you can see the lysis beginning on the lower part of the image. So these are confocal micrographs using TPA, and what it shows is that it takes 6-7 minutes for the clot not being halfway drenched with TPA. And so there is a lot of time that it takes for the TPA to take action. So what we really need to know is, how does this differ when you use TNK? And we do have this data. This is a transmission electron microscopical study of an in vitro clot. And you can see on the left-hand side is the control. It is a slightly larger size. You can see 1 micrometer instead of 5 micrometers, so you can see it a little bit more clear. And on the right-hand panels, under B and C, you see TPA lysed in vitro clots. And on the D and E panel, you see the tenecteplase lysed clots. And then they also used ultrasound in the upper panel and the lower panel, C and E, in both TPA and tenecteplase. And what you see is a quantitative assessment that you can control, that you can compare with a control by your naked eye. And you can see that there is a fluffier distribution in the tenecteplase D and E, as opposed to the TPA under B and C in this in vitro fibrinogen clot. So what this group, a German group, has done is they have measured the quantitative weight loss experiment by weighing the clot loss after 1 hour in their experimental setting, according to treatment group, which I showed you on the previous slide. And to make a long story short, on the left-hand side is the control, 17.3 weight loss in percent. And then you see the other bars is either the TPA plus ultrasound, the tenecteplase, and the tenecteplase plus ultrasound. And to make a long story short, the tenecteplase is by 22% more effective in losing the weight, in lysing the clot in this experimental session than TPA. So that is the experimental evidence that we have to go into further clinical observations. And I just want to remind you of the history of all of this. The experimentation with alternative thrombolytics began back in the mid-1990s. And the clinical trials that have been conducted using various thrombolytics, including Ancrot, desmoteplase, and tenecteplase, were performed in the past decades. And TNK, tenecteplase, in particular, appears to be promising alternative to TPA, as I showed you before, currently approved for the treatment of acute ST elevation myocardial infarction. TNK is a genetically modified TPA. TNK has currently in stroke only class 2 recommendation in terms of strength, and B, level of evidence. I show you the data in a minute. So this is the difference between TPA and TNK. So TNK is a bioengineered TPA, and it varies in 3 sites and in a total of 6 amino acids. So you can see here in site 103, 117, and 296 to 299, TNK varies from alteplase, and what it causes is a different quaternary structure of this protein with different binding attributes to fibrinogen. So what are the properties of TNK versus TPA? So the fibrin specificity is higher, the thrombolytic potency is higher, the PA1 resistance, which is important, is higher, the fibrinogen depletion is lower, so this is an advantage in terms of the thrombolytic effect, and the PRT activity is a little bit higher, which is important in platelet-rich thrombi, which is what we usually see in humans. And then the clearance of the drug is much slower than TPA, and that is the reason why it can be given as a bolus, as opposed to a bolus followed by an infusion in the case of TPA. So these are the properties that translate immediately into in real life. So what about the dosing? So the dosing is something that has been always done poorly in thrombolytics. And for TPA, for example, there is no real dosing. The dosing, as you remember, in TPA is just, we said, oh, you know, cardiology, they use 1 milligram, we use less because there's a higher risk of bleed, so we use 0.9. There was never a proper dosing study done. And the same is true for TNK, except for this evaluation, which is actually published recently in Stroke and Vascular Neurology in 2021, looking at TPA versus TNK at 0.32 milligrams, 0.25 milligrams, and 0.1 milligrams. And it shows on the left-hand side the good outcomes, which seem to be the same in all of the groups, but you can see the bad outcomes in terms of death and bedriddenness on the right-hand side seem to be less in the 0.25 milligram group than in the others, although this is certainly not a statistically significant difference, but this is pretty much all we have. Then it has been used by the Australian group, in particular Parsons and Campbell in Sydney and Melbourne respectively, and now in Newcastle, and they started the journey in 2012 by looking at cases. These are human data published in the New England Journal, looking at alteplase versus tenecteplase in two doses, 0.1 and 0.25 milligrams per kilogram, in terms of the reperfusion as measured in PET scans, and in terms of the NIH score evolution in these different doses as compared to alteplase. And there seems to be a benefit in particular in the higher group of tenecteplase over alteplase in the 0.9 milligram per kilogram group. Then they continued this research over the years, and it was published again in an article in 2018 by Campbell. And these are higher numbers. This is a phase 2 study, you could call it, with 100 patients per group. And you can see there is a benefit of tenecteplase over alteplase in terms of increasing good outcomes and decreasing poor outcomes. Exactly the signal that we want to see in a phase 2 trial. And here is the assessment of the clinical efficacy in terms of the NIH stroke scale. And you can see that there is also a slight benefit of tenecteplase at 24 hours and at 72 hours in terms of the NIH over alteplase. So in Bergen in Norway in 2017, published in Lancet, was a trial called the Nortest phase 3 RCT. It was done at 0.4 milligrams per kilogram, so a higher dose. And there was tenecteplase 549 patients over 551 patients with alteplase. The study was hampered by slow enrollment, as you can imagine, in a small city in the huge country of Norway. They still had these infrastructural problems. The enrollment was very difficult. But as you can see here, there is also a slight benefit of tenecteplase over alteplase, as you can see in terms of the good outcomes. But unfortunately, in terms of the poor outcomes, there's also a very slight, non-significant higher likelihood of death in tenecteplase over alteplase, so that this is a wash. It may have to do with a slightly higher dose of 0.4 milligram that was chosen in this trial, but we will see in a minute how this story unfolds. So then we had a number of meta-analysis of TNK versus TPA in terms of dosing. And you can see in the upper graph, there is a 0.1 milligram of tenecteplase, then there's 0.25 and 0.4. And this is the typical finding of equivalency here. So nothing is favored at 0.1 milligram. At 0.25 milligram, there's almost a significant benefit of tenecteplase over alteplase in terms of the meta-analysis, and the higher dose, it bends back a little bit towards equivalency. So this mimics what I have already said in the previous 2 minutes, and we see here the first real-life experience. We don't have to go into too much detail. I only added this because it was the first study done. It's a retrospective study done in the US. I believe it was in Kentucky at 2 regional stroke centers using TNK, and 1 comprehensive stroke center using alteplase, and then undergoing endovascular thrombolytic therapy. And you can see here, just look at the p-values. There was hardly any difference, except to say that the tenecteplase group had a slightly higher endovascular treatment, 37 over 24%. The outcomes were very similar, and there was also no signal of any safety concerns in this first real-life experience retrospectively. But obviously more is to come, and this was just published recently, and I'm very happy that it was published in time for these talks. This is the intravenous tenecteplase compared with alteplase for acute ischemic stroke study in Canada, which was a pragmatic, multi-center, open-label registry linked, randomized, controlled, non-inferiority trial. So this is a mouthful. But it is an amazing achievement, and what we can see here is it's basically a phase 3 randomized study, and the interpretation I'll just give you in the beginning here is that intravenous tenecteplase at 0.25 milligram per kilogram is a reasonable alternative to alteplase for all patients presenting with acute ischemic stroke who meet standard criteria for thrombolysis within the 4.5-hour time window. This is the data. So you can see here the alteplase on the upper bar and the tenecteplase on the lower bar. We have here 765 and 802 patients. And you can see here it is basically a wash. There's a slightly higher group of 152 and 144 patients with NIHs, with Rankin scores of 0 and 1, and a basically equal number of death and severe bedreddenness outcomes. So this is a non-inferiority trial at the 5% level, and it shows here that both medications can be used with the same benefit and risk ratio. So if you look at the subgroup analysis, and this sometimes sheds some more light into the pathophysiology, it is a little difficult to say. I don't quite understand why alteplase might be, well, it's equal here, but why is tenecteplase better in the younger patients than in the older patients? I don't know. Male, female, also difficult. In terms of the NIHs, there should be, if anything, a rising increase from mild to severe, which is not the case. So it's pretty much a wash. There's one interesting signal here in the strokes that are a little bit later. So after 180 minutes, they seem to do better with tenecteplase, which may have to do with the fact that it actually works faster, as we have seen initially in the in vitro models. And so, but that's the only item that I would like to comment on. The rest is pretty much a wash, and whatever you decide to do, you're good to go. So in conclusion, TNK is a bioengineered cousin of TPA, different in only 3 sites of the protein. TNK is more selective, faster in onset, and easier to administer. Clinical evidence suggests that TNK is safe and as effective as TPA, and this may make it advantageous in bridging patients because we don't have that much time for the drug to start working, or treating those in the later parts of the 4.5-hour time window. The dosing mostly used is 0.25 milligram per kilogram, which is half the dose that's being used for MI. And further, phase 3 trial was presented in the Canadian collaborative study. So with that, I would like to thank you for your attention. Thank you.
Thank you, Professor Krieger, for this nice presentation. The message is well delivered about the non-inferiority of the TNK and how it can make different. Definitely, we'll have questions through our Q&A box. I will advise all the audience to use that box for their Q&A, which will be at the end of the session. Thanks again, Derk. I will go to our second speaker, Professor Bassem, Yousef Sheikh. Professor Bassem is a professor of vascular and endovascular and skull-based neurosurgeon at Taibah University, Madinah al-Munawwara, Saudi Arabia. He did his undergrad study at King Abdulaziz University, Jeddah, and then received his MD from Maastricht University, Holland in 2008. Over the last 30 years, Professor Bassem had an experience in the field of neuroscience and neurosurgery. He had numerous publications in international journals, book chapters, book reviews, and scientific reports. Professor Bassem has been invited as a speaker chairperson in more than 170 international neurosurgery symposium. He holds 2 patents for his innovation for endovascular neuroendoscopy for 3D aneurysm clip application. He received many awards, including the Best Research of the Year in Saudi Arabia in 1997, Prince Mohammed Award for the Best Scientific Work of the Year in Saudi Arabia 1998, and the gold medal from the European Inventors and certification of excellency from the Romanian Inventors Forum, and the best scientific achievement in 2009-2010 from at Dammam University. Tonight, Dr. Bassem is going to speak about the transradial approach in neurointervention and his experience in Saudi Arabia. Please, Professor Bassem, welcome to the stage.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا وزدنا علما. جزاك الله خير دكتور سهيل على هذه المقدمة اللطيفة. I thank the organization for inviting me to share with you our experience in the Madinah region with the transradial approach, where since 2016 we are disseminating the message that definitely when applied properly and carefully, it is doable and possible, especially with the neurointervention career. We face many patients with a vast majority of catastrophic pathology, including the acute ischemic stroke. So patients are already facing dangers. We should extend our hand with gentle, including the type and the method of procedures that we apply. In the late 90s, we contributed with different types of skull-based approaches for the cerebral aneurysms. Later in the 2YK, we made significant modification of the eyebrow approach to cerebral aneurysm of both the anterior and the posterior circulation, which we still use, and we extend much of the several other techniques. Now, in many of the meetings, and still till now, when we meet internationally and locally, we always hear the term clip or coil, coil or clip. But now even we are going into a more dilemma, whether we stick to our tradition of femoral approach or we go for something that is new for some of us, which is the transradial approach. Actually, the transradial per se has been used in the 80s, which is started by Radner, where he performed a cut down for the radial artery and introduced a catheter. So in a word or another, this was the first transradial procedure. Now, with time, the cardiology have advanced in the utilization of the transradial, where it became a standard of care in the late 80s or early 90s. It was only until the 2000 when Matsumoto have introduced the procedure for the neurointerventionist. Now, since the 2016, we introduced the transradial approach in neurosurgery, but it was a stepwise, careful introduction. It was started by a nice lady who refused totally the exposure of her groin, and she informed us that the cardiology are using the hand, why you don't? So from that time, I made a commitment with our cardiology colleagues in the center, and we worked together to improve and start the transradial approach. Initially, we were only, as most of us in the world, using the transfemoral. Later, we realized that radial is equal to femoral from the point of view of utilization. Later on, we jumped to maybe radial should come first. But nowadays, for the past 2 or 3 years, we are using the radial first approach. And then, if needed, then we can utilize the femoral. Now, I will share with you some of the tips that we have learned along our journey. Definitely, the radial artery has some beneficials, although it is much, much smaller in size than the femoral, but when utilized properly, it is easy to locate from anatomy point of view. Hemostasis at the end of the procedure is much easier. The ambulation, if it is diagnostic, it is almost immediately after the procedure. There are no major critical structures beside the radial artery, and we should always remember that the hand has a dual blood supply. Thus, if appropriately examined and evaluated, we can depend on the ulnar artery in case the radial artery went into spasm or thrombosis. Now, gradually, the cardiology colleagues have became a radial first users, and they considered this in their literature as a recommendation class 1. It was later that we in the neurointervention started to see some of the reports on the transradial approach, initially diagnostic, later therapeutic, and gradually it's not only the standard scheduled procedures, but also for the top acute management like the acute stroke, mechanical thrombectomy that nowadays we apply. And in the literature as well as in our hand, it has been shown to be of much safer than the transfemoral approach. Now, we all know from the application of our neurointervention procedures that with more and more advancement, we are utilizing a larger and larger pore catheters, guiding catheters, and guiding sheath. And this entitles a larger corridor. But when we talk about the radial artery, you cannot introduce a large pore catheter into a small artery. We should remember that the femoral artery diameter is much, much larger than the average radial artery. And in our Saudi population, from our observation, we found the maximum radial artery to be between 3.3, 3.5, but the average is 2 millimeter. This what led us initially to use the small catheters like 5 French or 6 French, but we realized that definitely they are not always suitable for each and every therapeutic procedure where you need a larger pore catheter or sometimes a double access points. And that's why we moved initially to the utilization of the 8 French catheters like the NeuroMax and the acute stroke management with the flow gate. Remembering always that the outer diameter is 2.6, we use the ultrasound to decide whether we are going to be able to utilize larger pore catheters in each and every single patient. Now, with the introduction of the wrist radial guiding system in our center, we found that we can compromise by from 8 French to 7 French, which in most of the cases, it is really suitable for the management of the different microcatheters, balloons, intermediate catheters, and so forth. And I will also show the advantage of utilizing the wrist system later on. Now, with having the large pore catheters, then we have more options of utilizing multiple microcatheters, intermediate catheters, large intermediate catheters, and microcatheters or balloons. So it always starts by the atmosphere. And definitely the radial approach is not different, because you have to utilize your angio room, but specifically for the radial, which means that your access point is at a different level, your catheters and materials are on a different level than the femoral region. So in the market, there are really designed, dedicated tables and accessories for this, but it might be either expensive or might not be available at your center. And this is what led us to make a very simple modification by putting a standard table rest, which is under the mattress where the patient will be lying, so it is well supported, and the regular arm rest. So at the end, you have the patient in the usual situation, lying down on the mattress. The hand is extended out. Once the access has been ensured, then the side armrest will be pushed inside, and then the axis of work will be the same with your table with all the materials and equipment. Second, you have to have a dedicated team. You cannot do this alone. The education, the knowledge should be shared by each and everyone available in the angio suite, from the nurses, technician, anesthetist, and the operators themselves. And initially, it took longer time, more effort, but with time, with patience, they will be more aware about the procedure, and it came as a standard, same as the femoral approaches previously used. Now, in each and every patient, I insist on having either a CT angiography or MR angiography, which is done from the aortic arch up to the vertex. And this is specifically to see the route that you will be approaching. So in other words, from the radial, or now recently we are utilizing the ulnar, so the radial or ulnar until you reach the subclavian. And sometimes if you are not aware of that, you might face a innominate right side subclavian, which is arising behind the great vessels and arising from the left side of the aortic arch. So it will make the procedure more complex and time lengthy. So the study of the preoperative CT angio and MR will give you a valuable information. Now, always safety first. And although our colleague in cardiology departments in the center, they do not believe in performing routinely the Allen's test, modified Allen's test, and the Barbeau's test utilizing the Doppler ultrasound. They immediately go and do the procedure. We insist on having the pulse oximeter applied and the ultrasound utilized in each patient. Even we look at the palmar arch circulation after occluding the radial artery, and the main difference is that we are utilizing more and more of the larger catheters like 7 and 8 French guiding sheath or guiding catheters. Ultrasound is very important. For the past 7 years, all my procedure is ultrasound guided. This improved significantly on the first puncture access without having a failure or a local hematoma and so forth. So we always locate the radial artery under ultrasound, do the puncture after measuring the size of the radial artery itself, so that we decide on the size of the guiding sheath or radial sheath that will be utilized. We even nowadays, we don't use the fluoroscopy to follow on the initial guiding wire introduction, but we use the ultrasound itself to locate the wire in the middle of the artery for safety, and then we introduce the sheath inside. We don't insist on a specific location as per textbook, like 4 centimeter, but we again depend on the ultrasound, so we pick the most suitable part along the radial artery, whether it is the snuff box point or the more proximal radial artery. We started only with utilizing the right side, but then later on we found that we are in need of the left side for special cases like the innominate right side subclavian that I showed you, or in cases where you have a left pathology on the vertebral artery. The utilization of the left side is not a big deal. It is the same as utilizing the right side. Once the access is guaranteed, then the hand of the patient is leaned over, his abdomen is secured in place, and the operator will work in the usual fashion from the right side, facing the monitor as with any other procedures. The utilization actually of the ultrasound has helped us significantly in using and reusing of the same radial artery. We can utilize it up to 3 times in our patients. We start with, sometimes we give local anesthesia, but in most of our patient under general anesthesia, we don't insist on utilizing the local anesthesia, and we go immediately on a very careful and gentle puncture of the radial artery under ultrasound guidance, And then each center has a different radial cocktail that utilize, and this is our own preference. Now, when we started, we used to go with our cardiology colleagues, observe and do under their direction. But later on, we realized that it is two totally different ways. Once the cardiologists are inside the aortic arch, then they are immediately in a direct location to the heart or the coronary arteries, while from this point, our journey as a neurointerventionist start, and it is almost in an opposite direction than you are coming from the subclavian artery. So this needs a real dedication and patience with the experience that you build slowly and carefully. And this is to know how to handle the catheters, wires in a sliding fashion rather than in a pushing fashion that may lead to unwanted complications.
Yes, Prof.
I don't know if this hanging is from my.
Yeah, we can hear you, Professor Bassem. Yes, it's there. Go ahead.
Okay. So in a usual.
Yes, please continue.
طيب, Dr. Suhail. So in a usual case, we start with the introduction of the wire catheters. We started with a straight tip wire as recommended by our cardiologist, but then later we found that a J-shape is possible, doable, but we always insist of advancing every single millimeter under fluoroscopy so that you avoid the introduction into one or another of the side branches from the radial artery. We usually start by the ipsilateral radial vertebral artery and then go to the aortic arch. We start cannulating the carotids on both sides, and then we go to the subclavian on the opposite side if needed, and do the left side vertebral artery. So this is simply the routine that we do. Once you are in the attended location of the site you want to do, then the procedure will be as usual. The catheters differ tremendously. In order to be able to approach from down angulation again to the cranial, definitely the usual catheters that comes from the femoral approach is not useful, and then we have to train on utilizing freely and fast the complex curves, which is the Simon's catheters. Once you are there, you can use your, as we said, the 8 French, the 7 French, as you intended with your procedure. Now, a word about the wrist radial system that we experienced is that it is really of useful when you try to cannulate a acute angle origin of the arteries from the arch of aorta, and we take the technique of just introducing the Simon catheter, but later on keep the Simon in place and advance the wrist. We found that it is really has a good pushability and is a trackable guiding catheter. The upper limb angiography, we used to do it in each and every case in the start, but in later years we do it selectively, depend on the case, especially if we are reusing the radial artery twice or 3 times. Now we either introduce a radial sheath, or we use the sheathless technique if we are utilizing large bore catheters like the Neuron Max 8 French. The wire and catheter advancement is always advised to be under direct fluoroscopy view, and this applies even more when you are utilizing the transradial approach. Once the carotid or the vertebro-basilar system is cannulated, then you can apply the same techniques for any pathology as you apply via the transfemoral, and this is one of the cases that have total occlusion of the MCA and an acute presentation, and a combined technique of stent reaver and distal aspiration catheter yielded in a good revascularization in time. This is another recent acute stroke management where has a floating basilar thrombus at the whole length of the basilar artery with right side vertebral occlusion. The approach was straightforward. The revascularization was established. The patient was found to have a ICAD pathology, and this will be dealt with stenting later. The same will be also utilized even if you are using multiple catheters and microcatheters like for coiling, balloon-assisted coiling, stent-assisted coiling, or flow diversion. Now, once the procedure is done, then the pull out of the catheter should be very careful, because what you started nicely and gently, you want to end it really nicely and gently so that you don't apply a force and then stimulate the radial artery for a spasm. So we take time and careful in ending the procedure. Once this is done, then we insist on measuring the pulse oximeter and do a patent hemostasis rather than shutting off the radial artery total by pressure, but we apply pressure until it is needed for hemostasis, but it will not shut off the radial circulation. And we test this by applying also the pressure on the ulnar artery so that we make sure that the radial artery, bi'idhnillah, is reusable later. This is just a technical note that for our distal artery approach, which is the snuff box approach, we don't have available a special bands that will sit in place without moving. So we utilize the fully catheter. We inflate it with 2 or 3 cc of saline, and then apply it for the same time as you are applying the radial cuff. Bottom line, I'm really convinced that the radial approach as the first approach is really doable. It is safe in a good, careful, dedicated, and learned the techniques hands. Now, patient satisfaction, we have really touched it, especially with those who are coming for diagnostic and leave. Although I should mention that I'm more toward using it for those who are therapeutic, especially those who are on dual antiplatelet or an anticoagulant as the cardiac patients, because then you will not worry about bleeding after removing your femoral sheath. The operator satisfaction, I'm really going for that, and this applies also for the whole team in the angio suite. But you have to be careful that it is doable, but you should have a really dedicated learning so that you will not go into any disaster. Talk, I really could convince, if not all of you, but most of you, that it is a possible cast. Thank you very much.
شكرا جزيلا دكتور باسم جزاك الله خير والله ينفع بك وبعلمك إن شاء الله شكرا جزيلا. Thanks for Dr. Bassem. All the audience, we have a nice number there, and you can address all your Q&A in the box down there. So Dr. Derk is joining us in a few minutes. He sent the WhatsApp that he will join in 5 minutes. So Dr. Bassem, a clear question, which I will direct the same questions to Dr. Derk. Why do we need to change the practice from femoral to radial and from TPA to TNK? So your question is why radial instead of femoral?
Why do you want to change from TPA to TNK?
That's the question which Derek will answer.
So we are always in a search for what is best for our patients. If we started, as I showed, with a huge skull-based approach, that was for the best of our patients at that time in the 90s. Now, later on, we progressed with that. We found that we don't need this exposure, and we might benefit the patient with less risk with the eyebrow limited approach. Now, the same goes with the femoral radial. Is not contradicting, but they are complementing each other. Sometimes I use both in the same patients if I need the multi-axis. So they are not contradicting each other. They are not deleting each other. Whatever is best for the patient, in my opinion, should be utilized.
Interest. There's a question from one of the audience. Thanks for your comprehensive talk. Do you get any incidents of ischemia or dissection in the radial artery territory?
I face vasospasm, and one case only I faced a severe vasospasm. We were using, of course, as usual, we measure the radial artery, we give the vasodilator, the radial cocktail. I was using an 8 French catheter. By the time I reached the subclavian artery, I felt that the neuromax was not moving easily. So I stopped, I made an angiogram, and then I realized that I have a very severe vasospasm. We applied several techniques, starting from physical, like a warm packs, to a additional vasodilator, to additional local anesthetic around the catheter itself, which is the radial artery, but it did not open. So I left it in place and we went for the femoral approach. By the time we finished, we called for the vascular colleague, but the catheter smoothly came out, walillah alhamdulillah. So yes, it happens.
Okay. There's questions from Dr. Rosario, who's a neurointerventionist. In acute stroke setting, do you use also 5,000 unit of heparin in the cocktail, or different approach you will have?
No, even in the acute stroke management for mechanical thrombectomy, I give the 5,000. This is a let's say a regime that is always applied, except in the acutely ruptured aneurysm. I don't give it in the beginning, but I give it after the first coil or after the flow diverter, if applicable in the acute stage, is in place.
Interest. There's questions from Dr. Yasser Al-Ali. Good evening. Is the incidence of arterial spasm is more in the radial approach than the femoral from your experience?
I cannot remember a case of femoral approach that I faced vasospasm in the femoral artery per se. I really cannot remember over the past, let's say more than 20 years. But in the radial, yeah, it happens of different degrees, maximum the one I just mentioned.
Okay, okay. There's a question of how many centers in the GCC country, the Gulf country, that they're using the radial approach for the neuro intervention, including stroke or clipping, aneurysm, or diagnostic?
I don't have an answer for that.
In Saudi
But I'm
Arabia?
sure in Saudi Arabia, yes, we have centers in Riyadh using it.
Okay.
King Abdulla Medical City is one of the largest centers for the neurovascular. And yes, we are proud that they are utilizing the radial approach. I don't know how frequent, but I'm sure that they are utilizing it.
One of the questions is regarding the timing of thrombectomy. You spoke about that before. We are doing the procedure, we will do the ultrasound, we will do this and this. In acute setting for acute stroke, do you think that the timing for a thrombectomy is different between the femoral approach or radial, or there's no difference?
There is difference. And that's why the operator should not start by doing the acute stroke management or mechanical thrombectomy via the radial artery until he or she is 100%, not only himself or the assistant, but the whole team are well oriented with the steps. So in the beginning, yes, we had some time looking at the ultrasound, checking which side is better, checking which probe of the ultrasound will show me more, and then moving the probe in different methodology, longitudinal or cross-sectional. It took us time, but this is on the non-acute cases, the cold scheduled cases. Later on, when it was a habit rather than a must to do. It was a habit to have the ultrasound. They are preparing the radial cocktail and so forth.
Let me to clarify this again, because I'm not sure if you addressed this. So Professor Bassem is saying that radial will need more experience to learn. It's and if you are doing the emergency cases of thrombectomy for the neurointervention or a neurosurgeon who's doing this, you recommend them to do the radial on a cold cases, scheduled cases before going for a midnight thrombectomy case. Is this correct?
Agree.
Agree. Okay, there's a question here. Thanks for comprehensive instead of ischemia. We spoke about. Which type is less in complication from your experience between radial and femoral?
If you are talking about the, for example, complication about aneurysm coiling,
aneurysm and others.
Yeah, once the intended artery of interest is cannulated, then it is of the same magnitude, whether you come from the femoral down or from the radial on the side.
Okay. So a question from Dr. Muhammad: does transradial need anesthesia? Anesthesia is different from the transfemoral anesthesia?
You mean local or general?
I believe he's mentioning here the local one.
The local. As I mentioned, those who are going for therapeutic, and most of our patients are going immediately for therapeutic, except for the patients who are post-procedure follow-up local. Mm-hmm. I mean diagnostic. So we use the local anesthesia. But for those who are going under general anesthesia, whether due to their clinical condition or because of the procedure itself therapeutic, then I don't like to use the local. Number one, it will make the ultrasound hazy in my hand, in my experience. And I sometimes find that the distance between the skin, the puncture and the radial artery will increase by the amount of the local anesthesia. But this is only my observation.
Okay. A question from Dr. Muhsin Badran. What does the ultrasounds have to do? I believe that the question is why we are doing ultrasound for these patients.
Well, in general, any access, I do it under ultrasound for the past years. Femoral approach or radial approach. This gives me a very clear vision, direction, angulation, and the site that I will put the needle into the arterial wall. So whether it is radial or femoral, I use the ultrasound.
Okay, so that's a very clear answer. There's a question, very smart question. Are you concerned about the right or left-handed patient in the approach or by a problem in the right forearm? Do you move the table if you wanted to use the left radial artery? Why not the ulnar artery? So two questions. Left, right, how to decide? You said that your table, which has been designed and modified by your team for the right radial. How about the left side if the patient is right-handed? Second thing is about using the ulnar approach.
Yeah, I have shown the table with the operator standing on the right side in the usual fashion, looking at the monitor as we all do. And that was a left side approach. So initially, I will be on the left side of the patient. I do the puncture under ultrasound, insert the radial sheath or the guiding catheter, and then lean the left hand of the patient over the body. And then it is fixed with the drape in position. Now, from here on, the same applies like you are performing the procedure on the right arm side.
That's
now,
very
yes, yeah. Regarding the ulnar, since 2 years, we are also utilizing the ulnar artery. Last patient, I remember, had a innominate right subclavian. So we did not want to use the right radial artery. On the left side, she had an accessory radial artery, and both the main and the accessory were of a small size. So we utilized the ulnar artery on the left side.
That's very interesting. Dr. Bassem, there's a question from Dr. Haydar Saleh. Thank you for your great talk. May I ask about the radial artery dissection if you faced before in the radial axis? If you had it, what you are doing with that? That's his question. If you had any dissection with the radial.
No, I did not have till now. Walillah alhamd.
Alhamdulillah. Alhamdulillah. So I advise everyone to go there to look for this one. There's a question for Derek. We're trying to get Derek. He should be here. There's about 10K again. Thank you for who's approached you. There's a question from Dr. Mohammed Al-Kuwaiti, consultant neurologist and stroke specialist from Al-Ain. Thank you for nice talk. Who are the best candidates for the radial approach? And do you use it as a default procedure for all your patients and keep the femoral approach as a backup?
Yeah, for the past years, we adopted the technique of radial first. So all patients are candidate for radial. The whole team.
These are for both scheduled and emergency cases. Is that correct?
And emergency. Yes, you are correct. Both of them. They are all candidate for the transradial with exceptions. And we mentioned in the beginning that CT or MR angiography will play a role in deciding whether this patient is a candidate or not. And then ultrasound just before the puncture will decide whether the size of the radial artery is suitable or not.
Okay, okay. There's a question from Dr. Tahir Al-Dabbagh. How come the number of times to access radial is only 3 times as mentioned?
If he means the maximum times are 3?
I'm not sure that.
This is the maximum time of a patient, a single patient, that I needed to perform procedure on him. So we did the first time, it was diagnostic of a complex pathology, but then the second time was the first session endovascular embolization. The third time was the second session. So I don't know, maybe I have a patient with 4 times.
The last questions that I have here up to now is, can you use radial approach for all endovascular techniques like balloon assist coiling or stent assist coiling?
Yes, we do. And this depends on the guiding catheter that you will utilize. If you are coming through the femoral artery, then you would like to have a large pore catheters. And this is whether it is 7 French or 8 French guiding catheters. And the same applies for the radial. If you inserted the guiding catheter in a distal position, whether carotid or femoral or vertebral artery, then the procedure will be converted totally exactly like we are performing it from the femoral approach.
Okay, so now I will answer a few of the questions that came to Dr. Derk. I'm not sure what's happening. We are trying to get him. TNK has a higher rate of brain hemorrhage, which required anti-factor 7A. I'm not sure about that, really. It depends on the dose. 0.4 showed the risk of a bleed is higher than 0.2. And currently, the standard dose for the TNK is 0.2. That's what's coming from the recent release trials. So we start in Dubai at City Hospital to use for few cases. And I can say definitely we didn't see any higher rate of a bleed compared to the TPA. And that also from the literature. Questions from Dr. Waqar or Waqar. So mentioned in the data showed that TNK better than TPA. The data didn't show that it's better. It showed that it's not inferior. So it's equal for the TPA. That's very important. And your question, why guidelines said it is similar to TPA? Because it's similar. It's non-inferior design study showed that it's equal for the TPA. There's a question about availability of TNK. That is very important issue that all centers need to look for. The pharma, which is providing the TPA and TNK in the region, are the same company, and TNK is not available currently as much as we think, because they're used by cardiology and by vascular and neurointerventionists, so still is not advised. If I'm correct, the company said that by 2024 or 25, the production of TNK will be able to cover both area, brain and peripheral and cardiac also. Their question regarding the standard dose, Dr. Derk mentioned that in his presentation. It's currently 0.25 per kg as a bolus dose, which is much easier to be used compared to the infusion, Dr. Bassem. In your center, Dr. Bassem, for the acute stroke, ischemic stroke, are you using the TPA or TNK?
No, we don't have TNK.
Also, you don't have, neither the cardiology, they are using TNK?
No, TPA.
Okay. TPA. So that is one of the concern at the level of the globe. We have here our friend, Dr. Derk, showed up. Unmute yourself, Derk.
Yep, I'm sorry.
No, it's fine. I was bombarding Dr. Bassem with more than 20 questions. You showed up. Thanks for that. There's a question, Derk, regarding the list of contraindication. Is there a difference between the TPA and TNK contraindication list?
No, not that I know of. There's no difference.
Okay, that's good. A question, what we can learn from the cardiologist friends about using the TNK instead of the TPA regarding safety profile?
Yeah, it seems that the cardiologists we can always learn from them because they just have 10 patients when we have one. And so they have much more experience when it comes to safety questions, which you were alluding to. There is no signal in the cardiology studies, and they're using twice the dose than the most neurologists do, of 0.5 milligram, and they have not seen any signal. There was this one study that I showed, which had a little higher rate of this angioedema of the tongue in the patients with the tenecteplase, but I have not seen this in particular in the Lancet study that was published with the 750 patients times 2. So the safety profile seems to be very similar. I would like to emphasize again that the drugs are equivalent. So one is non-inferior to the other. So tenecteplase is actually non-inferior to alteplase. So alteplase is first choice. And so the tenecteplase is what I use in those patients where I think, you know, if the clot can be opened by thrombolysis in time, then the tenecteplase will be probably a little quicker, as I showed you in the in vitro data, 22% quicker than the TPA. What is 22%? Well, it translates into time, and time is brain, so it may make a big difference. So if I'm in a later phase of 3 hours, 2 hours, 30 minutes or something like that, I'd prefer to use this drug because it will be quicker. In the very early phases, if you get the patients within 45 minutes, there may be no difference. But later, I think there will be. We have seen this in the subgroup analysis of the Lancet study as well. And then if you have, which most centers now do, if you have the opportunity of treat patients with endovascular treatment, then if they come into your door and you have your door to groin time of an hour, it doesn't make any sense to treat them with TPA. You better treat them with TNK. So you have a better chance to soak this clot and make it better outcomes.
Good. There's another question which is a little bit long from Abdulla. Thanks for this presentation, and thanks for Professor Bassem and Dr. Derk for both their comprehensive talk. My question is, however, directed to Dr. Derk. Sir, you have showed multiple studies of different dosage of TNK, whether it is 0.25, 0.1, and 0.32. I think he skipped over 0.4. There was a study that showed 0.25 milligram per kg, showing the highest benefit in the term of less death and higher success rate of recanalization. Was there any conclusion on 0.4 milligram per kg dose?
The 0.4 milligram dose was used in the also Lancet published study from Norway, from Bergen. It was a study that enrolled in 2012, 13, around this time, and was published in 2017. I don't know why they chose to use the high dose, because the studies from the Australian group were already out there, and they were proposing 0.25. But anyway, this is what they did. And if you look at the data, it showed a slightly higher mortality, not significant, but in terms of numbers, and in rankings of 5 than in alteplase. Whereas the outcomes were not much better. And so I think it doesn't make a lot of sense to use 0.4. There's not a lot of evidence to suggest this. Most people, in particular the Canadian collaborative study, have used 0.25 and shown that it is non-inferior, and that the bad outcomes are smaller, and the good outcomes are about the same. So this is what I would take as a take-home message. And I would like to reiterate what I said in the beginning. The dose-finding studies for TPA and TNK have not been done the way that they should be done. And you may remember that for TPA, there's a lot of studies using now 0.6 in the low NIHs, and these kind of reiterations of the team. We wouldn't have to do this if we would have had a good study. The same will probably happen with TNK. So it is what it is. We live in these non-ideal times. But if you have a patient that comes to the hospital with an NIH of, let's say, under 8, and you treat them with TPA in the early window, or you treat them with TNK in the later window, then what I would do is I would use 0.9 milligrams of TPA or equivalent of 0.25 milligrams of TNK, and you can assure that the outcomes are as good as they were in the ININS study. And that is our gold standard. And so, we can discuss this and we can do other studies, but I think we should move on and try to improve the infrastructure of getting the patients or more patients earlier in for these treatments, then to discuss whether we should increase it by 0.05 or whatever. This is not making a relevant difference, I think.
Oh. Thank you, Derek. Professor Bassem Yousef, there's a question regarding when Professor Bassem will decide not to use the radial and will go back to the femoral, in which cases?
We mentioned some of the cases that anatomically, the pathway is not suitable. Mm-hmm. The radial artery is of small size and they need a large pore catheters. The right radial or ulnar approach will end into an innominate subclavian that will make the journey a little bit tortuous and will be lengthy, although we had 2 patients like this, but it will increase on the time and of course the risk for the patient.
Okay, thank you. We have 3 questions to be ended with. Dr. Derek from Niski Ortez. Doctor, any additional pre-medication medicine can be given to a patient with acute stroke prior to administration of TNK?
I'm not sure what kind of medications he's referring to. Is he referring to...
I think he's speaking here about the neuroprotective and all those trials about magnesium and different things has been given which showed negative trials studies.
Yeah, I think this is still an important issue. When I was a resident or a young consultant, we were thinking, we have IV TPA or thrombolysis or thrombectomy, and then we're going to add a neuroprotectant and we're going to be even better. The issue is that with thrombolysis or thrombectomy, you get a ceiling effect. So if you recanalize these patients effectively, they will do fine, whatever you do. And the ones that don't recanalize, they will not do fine even with the best neuroprotectant because it's not going to get there. So I think in terms of the use of neuroprotectants, and I still believe that hypothermia is one of them in the mix. I think those are the ones that you should consider along with endovascular thrombectomy, in particular in the patient with the posterior circulation, because those are still doing relatively poorly. But there's no drug that is a panacea for patients that undergo thrombolysis or thrombectomy. Suffice to say that, and this is an important issue for practitioners in areas where there's not such a high volume, be very careful with the blood pressure. You don't want to lower the blood pressure until the medication works. So don't use don't get the pressure down. If the pressure is 180 or 185, leave it where it is. Don't get the pressure down, because you reduce the acute collateralization of your penumbra. And then later, when you have had thrombolysis or thrombectomy, then you should get the pressure down. In thrombectomy, in thrombolysis, you should probably get some idea of what the effect was, either with a TCD or with some kind of an imaging study using CT techniques. But only then you can decide that your pressure should be brought down. So that's all I can say. There's not much more.
Thank you, Prof. Derk. Prof. Bassem, this question is from my side. Do you prefer doing the acute stroke thrombectomy or a stent retriever in intubated patients sedated, or do you like to keep patients awake?
Well, in our center, all patients for mechanical thrombectomy are done under general anesthesia.
Interest. Okay, so you and do you think that has any side effect, that because it's delayed the intervention, anesthesia needs to be available there to screen the patients, then dropping blood pressure, or there's no major complication from your end?
Time-wise, we don't have that problem. The main problem, and it is debatable worldwide, is the initiation of the general anesthesia that will drop the blood pressure in some time until the patient will be picked up again with a higher level pressure that you would like to keep around 180 or more until the mechanical thrombectomy is successful.
Okay, and usually, Dr. Bassem, do you wait till the TPA is finished then to start the procedure, or you can go ahead while the TPA is running?
No, we if the patient came in the appropriate time for TPA, then it is started from the emergency room while the patient is finishing his CT angiography, and then pushed to the angio. Once I'm about to insert the catheter with a radial or femoral, then the ايش اسمها؟
TPA.
Yeah, TPA, but the TPA flow will be stopped. The infusion, هذه الكلمة. The infusion will be stopped at that time.
Okay. Derk, the next question, Dr. Bassem, he doesn't have any problem with. The question is, TNK available in UAE for acute stroke. Any medical legal issue if used nowadays?
No, I haven't. No, it's not yet approved, so it's an off-label use. So I think when you do your consent, you have to discuss this with the family in as good as you can. But no, there should not be any legal issues with this at all. And when it comes to what Professor Bassem just said, the radial approach is certainly the safer one if you do a bridging therapy. And the problem with the groin is that there can be bleeds in the posterior wall of the femoral that you actually don't know. Only late, when the leg becomes thick and red, you see that there is a hematoma, which doesn't happen in the radial. So I think this is a very, very important contribution that we heard today to make the bridging treatment safer. So this is what I want to say. But in terms of using one or the other, I don't think there's an issue.
And that's what Dr. Tamer Zaidan, our colleagues, is asking the question next. Derek, any preference during bridging therapy, IV and mechanical thrombectomy between TPA and TNK? The beauty about TNK, it's one bolus over less than a minute, Dr. Bassem. Then patients can go directly and you don't need to do changing the syringe between 50 mg, which is prepared, to another 50, giving the bolus over a minute, then infusion. It's only a bolus, then patients will be on your table, Dr. Bassem. So is there any preference during bridge therapy between TNK and TPA, Derek?
I think TNK would be my choice, and it's simply because you know, this is evidence, expert evidence. This is not well. It is. There were some studies done with TNK and the reperfusion rate. The reperfusion rate is higher if you look at early Campbell studies in 2012 and 14. It is higher, but I think, you know, if you use a thrombolytic, an IV thrombolytic, the problem with it is that it may not actually reach the thrombus, because that's why there's a thrombus. There's no flow, and so even, you know, the best thrombolytic, if it doesn't get to the thrombus, and you saw how long it actually takes to munch into the thrombus, then, you know, and this is 290 seconds is like 5 minutes or so. So it's actually quite a long time. And so my experience is, and this is echoed by all of the centers where I used to work, is, you know, sometimes you open up the clot or sometimes you don't. You never find something, you know, 10% open or something like that. You improve it a little bit. No, it's either open or it's not open. It's either helpful or it's not helpful. And the same is true for if you do a thrombectomy and then you're not sure. It's 80%, 70% Tiki flow of 2.2A or something like that. And you say, well, let's give a little bit of IA thrombolysis. I've never seen that being effective. So this is like a yes, no. Black and white. It either works or it doesn't work. And so you don't have to be so worried as an interventionalist, because also the time of flooding of this medication is relatively short in both cases, by the way. And so I think what we can do is it would make sense to do TNK in a bridging, and then if you can choose between radial and femoral, I would definitely go for the femoral if I do bridging. I don't know what Professor Bassem has to say, if he agrees with me.
Well, I don't have experience, so I don't have any opinion.
About the TNK?
Yes.
About the TNK, yeah. But I mean, if you imagine that you have a medication that is in the system, has a very short half-life and has either done the job or has not done the job, wouldn't you be happy? And wouldn't you then say, well, the radial approach is still better than the femoral approach, because the patient, there's no bleeding risk when I use the radial approach?
Yeah, but it's if we came to the radial approach per se, is not only the bleeding, but also the other complications are more, as have shown by the multiple studies all over the world. So yes, I agree with you. It is one point. It is the faster pathway, which is the femoral. It has a larger diameter. Definitely, most of the interventionists are aware and experienced in the transfemoral rather than the radial. So in the majority, in the vast majority, yes, you are right.
We are reaching the 90 minutes. At the end, audience attendees, I'm so glad that I was chairing this webinar tonight with a distinguished two speakers, Professor Bassem Yousef Sheikh from Madinah al-Munawwara, microvascular, endovascular, and skull-based senior consultant neurosurgeon, who update us today about the radial approach and the experience from Madinah al-Munawwara, Saudi Arabia, and my friends, Dr. Derk, Krieger, a consultant senior professor, neurology, stroke specialist, who update us about the new approach with the TNK and update about the treatment that coming in the pipeline, and maybe will change the guidelines soon. At the end, it was my honor to be with you today, both my friends. I'm so happy that I met Professor Bassem for the first time, and soon, inshallah, we will be able to meet face and face. شكرا جزيلا دكتور باسم.
يسعدنا الله يجزاك خير.
الله يرضى عليك ويعليك.
نقطتين دكتور سهيل.
واحد سير.
بروف، الأولى واحد حلفني الدكتور عمر منصور النزهة
معروف نعم نعم
من كندا وقال لازم أوصل لك السلام
على هالخشم. الله يسلمك.
النقطة الثانية اليوم حسستني بأني سنة سادسة اختبارات سؤال ورا الثاني.
Thank you sir, thank you.
جزاكم الله خير. I'm very happy to be here with you. I learned a lot from the information and from Prof. Krieger.
Yeah, so and there will be the CME hours, 2 hours will be sent after you receive tonight or tomorrow a link that you need to fill for the evaluation, then you will receive the 2 hours. Just to let you know that the CME is accepted by all the GCC country. So the people from Saudi Arabia, they will receive their certification and the CME hours. We will see you next month, inshallah, with another webinar. And to remind all of you that on the 26th, 27th of October, inshallah, we will have the MENA Stroke Congress, which will be in Abu Dhabi, inshallah, with many speakers and update for more than 3 days with a workshop. All of you are invited to register and to attend virtual or physical. And have a great night. Assalamu alaikum wa rahmatullahi wa barakatuh. Fi hifdillah.
عليكم السلام ورحمة الله وبركاته. جزاكم الله خير. السلام عليكم.
Thank you so much, doctors.
Thank you, Derek. Thanks, my friend.